afternoon and welcome to the Waco Rotary Club this afternoon. We're going to start with our song leader, Larry Holsey.
All right, let's all rise and face the flag. Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we watched were so gallantly streaming, and the rocket's red glare of bursting midair came through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Please remain standing. Dr. Morrison will give our invocation.
Thank you, President Rosemary. Please pray with me. Heavenly Father, we come before your presence to give thanks for this meal and give thanks for the fellowship of Rotary. You've blessed our community over the years with great leaders, and we humbly ask you to bless our leaders today and going forward. Thank you for bringing us together today. Thank you for our community and our state and our nation. In your name we pray. Amen.
Amen.
And you can be seated. I'd like to introduce the guests. So if you just raise your hand. If you're a guest of a Rotarian, first we have Rebecca Eubank, a guest of Chris Eubank. Rebecca? Okay, and Michael Paparon, a guest of Curtis Brown. Tom Stanton, a guest of Harry Harley. Alfred Solano, guest of Harry. And Josh Carney, guest of Harry. Thank you, Harry. Joe Tracy, is that right? Did I get that right, Joe? That's right. Good. God, welcome. Thank you. Autumn Jones, a guest of Joe Riley. Mr. Erickson, a guest of Curtis Brown. Glad to have you. Sorry. Lynn Brown, a guest of Curtis Brown. Kent Claris, a guest of Evan Claris. And William Boyce from Amarillo. Amarillo. Good. Welcome to Waco. Great to have you. Thank you.
A few announcements. First of all, please welcome 3 new Rotarians. Ricky Ash with Sam's Club, Captain Chris Eubanks with McLennan County Sheriff's Office, and Aaron Shank, attorney and proprietor of the Inn on Austin Avenue. They were recently approved by the board. You all will expect an invitation to our orientation, so you'll learn everything you ever wanted to know about Waco Rotary Club. I also want to thank Kay Paul Holt, John Gimble, and Hayes Fuller for nominating these new members. Keep up the good work. We have applications available at the registration table, and so if you think of somebody that you think would enjoy joining Rotary, we hope that you'll take an application and submit it. It says you can submit it online, but please don't do that because it goes into cyberspace somewhere and we miss out getting it in there. So make sure Joanne receives it there at the Rotary office. Today is August the 1st. It's the 213th day of the year. It's Planter Day and Raspberry Cream Pie Day. So did you get my email last week? Yes. It Wasn't an easy decision to make, but it was made in the best interest of the Rotary Club to our future survival and growth. Our community needs a strong Waco Rotary Club to promote Rotary International's areas of focus, and we want to continue to bring that message to everyone that we know. So we hope that our move will increase our membership and attendance at meetings. So with that, we didn't come here to hear about my good news or bad news, whichever way you feel about it. We came here for a wonderful speaker today. So I'm going to ask Rotarian Harry Harlett, Chairman of the Day, to present our program.
Thank you very much. I'm honored today to present our speaker, Dr. Jackson Griggs. I have to apologize to Jackson, though, because I had 4 or 5 pages of introduction, and I had to cut it down so I would leave a little time for your presentation. Jackson is the Chief Executive Officer of Waco Family Medicine. It serves over 60,000 patients on an annual basis. He earned an undergraduate degree in English from Abilene Christian University and was recognized there as a distinguished alumni. He attended medical school in the UT Health Science Center in Houston and completed his residency right here in Waco at the Waco Family Medicine, where he was chief resident. He serves now as chair of the Waco Family Medicine Institute and is president and chair of the Waco Family Medicine Foundation. In addition, he's a board member and vice chair of Prosper Waco and McLennan County Youth Health District, and is a board member of the McLennan County Medical Society. Now, let's see if we can make this better. Is that a little better? All right. In addition to receiving numerous awards, including the 2020 Waco Person of the Year for contributions to community service during the COVID-19 pandemic, Jackson also trained over 150 resident physicians while on faculty at the Waco Family Medicine Residency Program. He's co-authored 30 peer-reviewed studies on topics of primary care, population health, and mental illness, and he contributed to the influential report by the National Academies of Sciences, Engineering, and Medicine. He's also a founding author of the Waco Guide to Psychopharmacology in Primary Care, a tool used by over 50,000 people globally and endorsed by numerous national medical organizations. I know you're going to be dazzled by a brilliant physician, a skilled administrator, a good friend to so many, and an incredible servant to and supporter of our Waco community. Help me welcome Dr. Jackson Griggs.
So the truth is, I sabotaged the mic because that's all really awkward, and you know, those things are sort of inflated for something that you send to an organization that needs a bio-sketch. You don't expect a friend to somehow get that from your executive assistant and broadcast it. So forgive me, and I wish the mic had failed entirely. I'm going to go use the mic in a minute, but I'm over here with Larry and Curtis, and I'm a little worried about Kevin, about getting over here behind the mic and missing the conversation here. So I'll try to roam. This is a tremendous honor, and I'm really grateful to each of you Rotarians for having me here. I have heard that you keep a hard 1 o'clock schedule and that you will stand up and walk out. And so I'm committed to concluding by 1 o'clock. I did tell my executive staff where I was headed today for lunch, and I told them my time limit, and I told them that I had 76 slides, and they have already harassed me to no end. So you don't have to do that. You don't have to give me a hard time. I'm told that it's impolite over a meal to talk about religion or politics. And so I'm not going to talk about religion or politics, as important as those things both are, but I am going to be insensitive to your meal when I tell you a patient story. Because it's a recent patient story that gives you an illustration of what we're about and why we do the work that we do. because we'll get into stats and we'll get into some of the numbers and how we fund an organization and what a federally qualified health center is. But I don't want there to be any confusion about the why. The why is the most important. The most important thing. This is a patient. This is actually image from Google. Represents a patient who I'll call Angela. I saw her in clinic a few months ago. Angela has 2 children. Married. Her husband was between jobs, and Angela was a cashier at a dollar store in a low-income neighborhood here in our community. And she was beginning to have, over about a 3-week period, beginning to have some abdominal cramping, night sweats. She began to lose weight, and then she began to have bloody diarrhea. And obviously that alarmed her. She went to the ER. Her blood count was not such that they needed to admit her for transfusion. They reassured her that she needed to see a specialist and gave her an appointment, called and gave her an appointment with a specialist. Between the time of her ER visit and that appointment, she had 2 more ER visits. And then the appointment was canceled because she didn't have $300 to pay for that initial visit to the specialist. Because of all of her physical challenges, she was not able to keep her job because she was having to miss work, relative incontinence, and some other things. And so she was in great distress, as you can imagine. One, she's having the experience of, what does this mean for my body? You know, am I dying? Is this cancer? How am I going to be able to make it? 2 is she's thinking about her children. My precious kids. We're barely eking out a survival on my wages as a cashier. How are we going to feed our kids? This is a real person who I'm seeing face to face. This is a real story. The good news is that we were able to expedite a visit to our sigmoidoscopy clinic. We were able to biopsy her, identify that she did have ulcerative colitis. Thankfully, it was fairly limited. Started her on medications, and her UC was controlled. And last time that I'm aware of her, I don't know that she was yet employed, but she was employable, and she was eager and ready to get back to the workforce. So, real story, and I wish it was exceptional. I wish this was outlying, wow, can you believe that person exists? We're right here, this is an incredible vantage point, and if you were to cast your eyes out the window, and just in one glance, there are thousands of people right here in this neighborhood, and that story is so common. It's just, our neighbors are shouldering such an immense burden of real disease. And right now I'm just talking about physiologic problems. If you overlay the mental health problems that are existing in impoverished neighborhoods because of the stressors that are experienced from birth. Now we know that moms who are undergoing stress, the genome of the child in utero is affected, such that there are generational implications for the kind of stress and experience that is yielded by poverty. So this is the why, because this person's, I told you not really sure politics, I'm already weaving off. This person's made in the image of God. This person is infinitely valuable. This person is worth our best. She's worth our best. And so that's why we exist. That's why we're doing the work we're doing. That's the why. And so now we'll get into a little bit more numbers. And I better pull out my phone, or I will break my rule that I started with. Okay, 12:25. I'm going to keep close watch on that.
When I was looking at Rotary's mission, I thought we are healthier all together. That being our motto, I pulled up your mission statement. The Rotary Club of Waco provides community leaders an opportunity to build lifelong relationships, promote integrity, and advance goodwill through service to our community and world. That is a beautiful mission statement. And I found there to be a great deal of alignment between the Rotary mission statement and the Waco Family Medicine mission statement. Our mission statement is to improve the health and wellness of the underserved residents of the heart of Texas by providing effective access to high quality, comprehensive primary care and by providing an exemplary training environment for tomorrow's family physicians and other healthcare professionals. So we're really I think connected. And I want to kind of zero in here on this point, access to high quality comprehensive primary care, because that may be a little bit of shop talk. And I want to make sure that we're all on the same page when we talk about primary care, because primary care can feel a little jargony. So I'm gonna define it here in a moment, but before I define it, I want to talk about its importance. So National Academies of Sciences, Engineering, and Medicine was established by Abraham Lincoln in 18-something, and it's a paragovernment organization to glean the very best in sciences, engineering, and medicine to help inform policy, and it ends up being one of the bodies that give guidance to how medicine as an institution, as an industry, is formed and forged in our country. And a group of experts got together to say, what's the path forward for primary care in the United States? And I don't know how many thousands and thousands of articles were reviewed in order to draft this, but in the literature specifically about what the value of primary care is, we're looking at health economics literature principally, and population health literature. The NASM expert committee said primary care is the only healthcare component where an increased supply, so the more primary care there is, where an increased supply is associated with better health outcomes and more equitable outcomes, better population health and more equitable outcomes. So if you add more primary care to a community, you get better population health and you get more equitable outcomes. So primary care should form the bedrock of any healthy and successful healthcare system. The authors go on to say, for this reason, primary care is a common good, making the strength and quality of the country's primary care services a public concern. So we should all be concerned about the quality of primary care in our community. And if we're interested in state and national health outcomes in the state and national primary care landscape. It's important to all of us if we believe in population thriving and if we believe in health outcome equity. World Health Organization, I told you I defined primary care, a model of care that supports first contact, accessible, continuous, comprehensive and coordinated, person-focused care. So I'm not taking care of an organ, I'm not taking care of an organ system, I'm not even taking care of an organism. I'm taking care of a human being, and that means something. You know, a human being is not a frog. A human being isn't a monkey. A human being is very unique, and to care for that human being means that we're more than the sum of our parts, and we can understand what makes a human human, which involves relationships, involves a proximal environment and a distal environment. Distal environment might be health economics, distal environment might be healthcare system, proximal might be what's going on in the neighborhood. What is making this particular neighborhood healthy or sick? What's the condition of public housing in our community? Those proximal issues. The NASM committee described it like this. Primary care is the provision of whole person, and that kind of gets at that same idea. Persons in that whole person, integrated, accessible, and equitable health care by interprofessional teams. So what you don't see here is that primary care is doctor-centric, right? It may involve, should involve doctors. I've spent the majority of my career training doctors for primary care. I believe very much in physicians leading primary care teams. But primary care shouldn't be doctor-centric, it's got to be patient-centric. And there's a difference there, right? So interprofessional teams who are, and I should probably also say, being now healthcare administrator, it's also not health center-centric or health system-centric. In other words, if we're just building empires, if we're contributing to the medical industrial complex, and we lose sight of the human being, we lose sight of that first image that I shared, we've lost the whole game. We might as well just pack up and all do something else, because we've lost our soul. So not doctor-centric, not healthcare, not health system-centric, but person-centric. Interprofessional teams who are accountable for addressing here it is, that comprehensive, continuous, the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. You see that idea of wellness there. It's not just about treating pathology. I mean, we have one of the most renowned pathologists that I have ever met in this room, and I know him well enough to know that he will say that pathology that I'm looking at under the microscope is critical, and it's not the only part of the story. There's other aspects, and you might identify the right pathology, but if the patient doesn't take the medicines in order to treat the pathology, what good is it, right? So all these pieces have to fit together. The pathology being vital, but whole person care being to the rest of the story. Dr. Morrison has saved lives. I have watched it happen in front of my life, in front of my eyes, time and time again. He's a hero for sure. So we've talked about mission. Here's the rest of the roadmap. History and context, how our organization is structured. We have 3 nonprofits that work in tandem. Kind of updates on current status. Briefly, want to mention our strategic plan, and then talk about innovations and differentiation. So I've got a bit of a task in doing this in the time allotted, so I'm going to move quickly and hope I have enough time at the end. So for questions. This is Dorothy Ott. We recently awarded her a Founders Award. She was one of our very first nurses, started in the 2nd month after our residency program started, and gave her professional life to the organization, caring for those. This picture is probably 1973 or so. Before Waco Family Medicine, the history of Waco contracted with Providence Sanatorium. So shout out to Kevin Stevenson, Providence, to take care of those who were in poverty. And they provided that service exclusively in our community. They continue to do a great deal of indigent care for those who are uninsured. But they were the go-to in our community for ambulatory, for outpatient, clinic-based care for those who were in poverty. And then in 1942, the health district said, we'll take care of this, and they spent some of the city funds in order to have a physician, initially a half day, and grew to 2 half days, 1 physician, 2 half days, to care for those in poverty. But fast forward to the 1960s, this was a time of a very dynamic time in our country. And locally in the 1960s, our average physician was 51 years old. So that's old for a physician population. And we had half of the physician density that the country had, the country average. So we didn't have many docs, and they were aging, and only 13 of our 140 physicians were, at the time, called GPs, general practitioners. They were primary care doctors. Only 13 were. And so the Medical Society, Joanne's here, Joanne Wade, who has been executive director of the Medical Society, and the Medical Society and Waco Family Medicine have long ties. It was the physicians of the Medical Society who said, we need to solve this. This is a health crisis, and we need to solve this. Not just for today, but for future generations. They knew that they had to do something that was a long game solution. And so they developed the Postgraduate Medical Education and Physician Procurement Committee. For all their brilliance, they weren't very good with naming. And then both Providence Hospital and Hillcrest Hospital each pitched in $10,000, which is a lot more money back in 1970, to establish a new residency program. And that is how we got started. It was our community joining with elected officials, business leaders, civic leaders, all linking arms going, we've got to solve this for the sake of our community. And that work was done in leading up to 1970 when we took our first class. And we were established to address the shortage of physicians, inadequate emergency medical services, inadequate services for the uninsured population, and the financial burden of free care that was being delivered in the hospitals and ERs. So obviously wrong location and expensive to provide primary care in those settings. So 1999, so we continued on from 1970 to 1999. Principally, it was a residency clinic that cared for those who were experiencing poverty and underinsured. But not much of a business model there unless you're getting funding from the feds in terms of graduate medical dollars. So we began to really struggle. We were borrowing money from the hospitals in order to make payroll. And Dr. Griggs, Alan Patterson, Tim Barker, a handful of great thinkers and leaders at the time said, what's a business model that aligns with our core kind of philosophic orientation, our ethos? And the federally qualified health center movement was happening across the United States. It started around the same time as our organization, 1970s, in Mississippi River Bayou, as a way in which it was the medical arm of the civil rights movement, a group of doctors and nurses getting together to say, how do we provide services to folks who are experiencing poverty, which incidentally were also people of color predominantly. And so Mississippi Bayou, Black community, first FQHC, the Fed said, wow, a lot of stuff is working here. A lot of things are working right here. We're seeing mortality change and the impact on the population change. So they began funding it. And then the FQHC, the Community Health Center movement, really grew. And now, 1 in 11 Americans receive primary care at a community health center nationwide. Supported, again, not religion or politics, I've already broken one of those rules, here's politics. It's supported bipartisan investment, consistently there's a bipartisan voice supporting it. You know, sometimes we, in our kind of the way that we lump things together in our partisan brain, which is a crippled brain, our partisan brain sometimes says, well, anything doing this kind of work goes over in this pot, and this kind of work goes over in this pot, but it's just not the case. This is great work that has tremendous benefit to people experiencing poverty and a huge economic benefit, and it sort of meets the mark on both sides of the aisle. And so we've consistently gotten, from the 70s to today, bipartisan support for FQHCs. But we were able to grow from 1,500 patients in '99 to last year, 61,600 patients. We have 15 sites, over 600 employees. And I mentioned kind of what a little bit about a federally qualified health center. So an FQHC, federally qualified health center, is think of it like a good housekeeping seal of approval. It's a stamp that the federal government gives an organization. We're a private nonprofit. We're not federal. We get a little federal grant dollars, but not a ton. But we're able to do the work we're doing because we get enhanced reimbursement for taking care of Medicaid and Medicare patients. So when we see a Medicaid patient, it's a big benefit to us. Now, docs out in the community will say, Medicaid, it costs me $200 to see a Medicaid patient, and overhead and salaries, wages, and I only get $60, so I'm losing money for a Medicaid patient. It's not the case at FQHCs. We want to see Medicaid, and in Texas, that's principally pregnant women and children. So we are able to, because Medicaid covers overhead, it helps us to pay salaries and wages. We see Medicaid as a the benefits, it maintains the financial health of the organization. So pregnant women and children are something that we need to see. And we love seeing women and children because that's probably in terms of leverage, lifetime leverage of health, that's the kind of critical window. So if we can see pregnant moms, even preconception, all the way through prenatal care, and then take care of those newborn babies and really give those babies high quality care through their childhood, we're probably making about the biggest impact we can in the sort of landscape of someone's lifetime. Okay, so couple other things about FQHC to mention. One is that our board is majority patients. So we're going, wait, you take care of folks who are experiencing poverty, and your board is predominantly patients, and that's true because we want to make sure that we are staying true to the purpose of the organization and not wandering off into a tangent that doesn't matter deeply to the target population. So patient majority, and then we don't turn anyone away for inability to pay. I didn't say we're a free clinic, but we don't turn anyone away for inability to pay. So we have a nominal fee if you're below federal poverty. Last year I think that was $13,550 for an individual, almost $18,000 for a family of four, household income, annual income, family of four, $18,000. So that's federal. That's what the federal government says is below that you have difficulty providing basic needs. And I'll show you a slide in a minute that 73% of those that we saw last year fall below federal poverty level. So 3 out of 4 folks who come through our door cannot provide for their basic needs because they fall below federal poverty level. People like the story that I told you. So we ask $10 when they come in. It's helpful to have some skin in the game. Now, if you don't have a penny in your pocket, you got to be seen that day. We'll see you. We'll waive that fee and see you. So we don't turn anyone away. If you're between 100 and 200% of federal poverty, we have a sliding fee scale. We give you a discount, and if you come in and you pay $20 at the door, that ends up being fairly minimal additional dollars that you end up having to pay for your health care, which is a really good deal if you're just trying to make ends meet. So, foundation. The foundation is critical. It was founded by business leaders in collaboration with physicians. Shelley Roten was a part of that in 1980, around about 80. And Tom Stanton is our president of the foundation, who has been just a magnificent partner in the work on, particularly on the central capital fundraising, and he's taught me a great deal about how to lead, and has become a dear friend. So Tom leads the foundation. He's our foundation president, owns real estate and makes major capital purchases that then the center leases from the foundation. The Waco Family Medicine Institute's the academic arm. It's the accredited body that it meets a whole array of regulations in order to maintain accreditation for teaching physicians family medicine, so the sports medicine fellowship, a clinical informatics fellowship, and a hospice palliative care fellowship. And then the center is what I run. I serve as board chair of the other two entities, but most of my time is spent in the center, which is the FQHC. So it's all 3 of these working in tandem that allows us to do our work. So current status. So I'm going to kind of set the landscape of the current status here by describing where Texas falls. And I love Texas. I've been here my whole life. I'm Texan through and through. So this isn't Bash Texas. This is, I love Texas, and there's a problem, and so we've got to heal Texas, right? So don't hear me getting on some California bandwagon or something. Of the 50 states, Texas ranks 41st for economic hardship index. 41st rank, that's an array of things including education level, upward mobility, employment. 41st out of 50 states. 45th for income disparity, gap between the haves and the have-nots. 45th for food insecurity. 45th out of 50 states in terms of access to foods for impoverished populations. 47th for primary care physicians per 100,000 people. If you look at McLennan County, incidentally, we're a bright spot in that because of the training program. We rank really high because of the long-standing civic investment in the residency program. But Texas, writ large, is very low in primary care physicians, desperately in need of more primary care physicians. 48th for preventative services. 49th for reproductive and women's health. 49th for availability of mental health providers.
And drum roll for 50th.
Some of you are already ahead of me, and you know where I'm going. Texas ranks 50th out of all 50 states for uninsurance. And over and over and over again, for decades, we've seen that insurance is tied with an array of outcomes. Lifespan, how your chronic diseases are addressed, whether you end up having to go back to the hospital multiple times, how frequently you end up in the ER, preventive care, a whole array of things. Mental health access. So being 50th out of 50 states for uninsurance impacts all of us. And we have a lot of folks who run businesses here. And how expensive is your healthcare insurance? It's hugely expensive. Hugely expensive. It's one of the major lines on your expenses every year. And why is it so expensive? Well, ultimately, the hospitals are going to see the folks who come into the ER. In fact, there's federal law that requires that, the entitlement. So they're going to see those folks who come. And a lot of those folks are coming in without preventive care, without chronic disease management, and they're super, super, super sick. Right? And what do you do with a super sick patient? You put a bunch of tubes in them, you give them a bunch of medicine, and then you send them up to the ICU. And you've got one-on-one nursing, right? You've got a lot of attention. You put them on telemetry, and so you've got a nurse watching the telemetry strip. You've got very expensive medicines being packaged carefully in a sterile pharmacy and then sent up to. It's super expensive to care for very sick patients, and so uninsurance, the cost of uninsurance ends up getting repackaged in insurance premiums that we're all having to pay in our businesses. So it's not as if we can turn a blind eye to this and say, well, economically, let's say we put that aside and start thinking about who our employees are. Well, if our employees aren't getting good care day in and day out in the ambulatory setting, they're not getting their mental health needs met, they're not getting their chronic conditions taken care of in an ambulatory setting. Well, it's really expensive to train a good employee, and then they start not showing, and then they end up taking FMLA, and then they quit. Oh, now I've got to recruit and train, and we bear the costs of unemployment that yields to, uninsurance that yields folks not getting the care that they need in a timely fashion. So this matters to all of us. If we look at composite health system performance, and this is an instrument or a measure that, based on cost, access, premature death, prenatal care, we can pat ourselves on the back because we're better than Oklahoma, West Virginia, and Mississippi. Not great in terms of our composite health system performance. This is just one of, I talked about reproductive maternal health. This is a key measure, and that is early prenatal care. 29% of women in Texas and Florida did not receive early prenatal care, compared to 11% in Vermont. And as Mike Harden says, is that Vermont's one of those states that you know, we don't really care where it is on the map. But I agree with you. But it's embarrassing that 29% of women who get pregnant don't get prenatal care when it matters. You gotta see women early in order to give them multivitamins to prevent the neural tube defects that cause lifetime problems. You gotta get to women early to screen them for gestational diabetes to avoid congenital heart disease and brain bleeds and an array of other things. So early entry prenatal care is really, really important. All of a sudden I got really insecure because Diane Sawyer, who helped train me as a physician's in the audience, I'm talking about maternity care. She said, stay away from disease. So you guys know this, I'm going to kind of speed up through these slides. We're in that growth triangle, so it really matters. What happens in McLennan County matters for Texas. I've already discussed with you board members in terms of who they are. They're on a volunteer basis. They do great work for our community. 15 sites, 4 of whom provide oral health, 10 sites provide mental health care, 11 sites provide maternity care. We're in both hospitals providing care. We have an in-house pharmacy, comprehensive lab radiology, we have an electronic health record for 23 years. We have the flagship EHR system, and that was pioneering thinking long ago. Our locations, if you look down at this little graphic in the bottom left, you see life expectancy at birth by zip code. It's an interesting idea. Life expectancy, overall life expectancy, at the time of your birth, based on, in other words, if I'm born in this neighborhood, what's my general life expectancy, as opposed to an equitable society would be, you look at this and it'd all be the same color, right? If you look over here, this population here is dying 15 years earlier than the population way over there. That's sobering. So where are our clinics? We've tried to build our clinics according to where the need is. We do have one rural clinic in McGregor, and we have one clinic in Temple. Temple has really dire women and children's health needs, and so we're in early conversations about building some of the women and children's services there in Temple. Last year, 61,600 unduplicated patients, just shy of 250,000 visits, and that has grown some. It gets wonky in COVID, obviously. By age, 56% are in that 18 to 64-year-old group, where this is our workforce. These are moms who are pregnant. 56%, over half are in that population. By income, I've already shared this with you, so I'm not going to belabor that point. 3 out of 4 folks fall below federal poverty level. 85, I got to do the math in my head, sorry, 69, 73. 73% of our patients by race are African American, Latino, or other. So we provide services to majority minoritized individuals. And by payer group, this got inflated during the public health emergency when the automatic process for rolling folks off of Medicaid wasn't in place. We had a little bit of a temporary experience of kind of gradually expanding Medicaid. And incidentally, parenthetically, if you are somebody who just doesn't know what you think about expanding Medicaid, that might be another talk I can come in and share with you. I don't know a community-minded physician worth their salt who is not in favor of expanding Medicaid. And I will preach on that. Give me a Bible, I'll use it. Thank you. It is, I know that it was founded in partisan politics, and I hate that because partisan politics demands our imagination. It co-opts our thinking, it co-opts our imagination, it monopolizes our devotions. It's akin to idolatry. And I just think that, I think the fact that it was founded in partisan politics is a shame because it matters to our community. It matters desperately to our community. So Medicaid, a third of our patients are uninsured, 8% have Medicare, 17% are private insurance. Difficult to fund an FQHC in Texas. My friends from other states go, how are you making it happen without expanded Medicaid? It is barely. We do have support from McLennan County. I want to shout out to Commissioner Jones, who has been a stalwart supporter of our organization, both in terms of annual funding as well as that $2.5 million grant to help us build a new building. Commissioner's Court's been immensely valuable and helpful to us. Great fondness for Commissioner Jones and his team. City of Waco, McLennan County, federal grants, and residency support from both hospitals. The hospitals receive federal dollars through Centers for Medicaid, Medicare, and they get dollars, and then they have a stipend agreement where they pay us to help support our residency program. So this is a long-standing arrangement, and they've been great partners with us through the years. Strategic plan, I'm going to kind of hit on this real lightly, but it's very valuable to us in our day-to-day operation. Access, you may know that we're building a building in collaboration with Behavioral Health Network. We are really grateful for our partners at Behavioral Health Network. It's a wonderful collaboration. We really aim to care for those people who are frequently in crisis care for mental health needs. We're working constantly on improving health equity. Like right now, we're training our staff to speak better Spanish in the exam room so that nurses who are doing translating get it right. Advancement, we're very involved in sharing our access and message to impoverished communities. And we're working hard to increase value in primary care by lowering costs and increasing population health and health quality. I'm going to just kind of, I feel like we've touched some on this, so I'm not going to spend too long on this, and looking at the time, I better not. I really want to get to, I'm going to jump across Institute here as well, to this. So our training program is one of the top in the country. The top 2%. Those who apply have standardized test scores that are on par with interventional radiology, dermatology. So our docs can do anything, and they're coming here to be a part of the solution in healthcare and in community health. We train them aggressively, and then a lot of them stay and work here in our community. We've got to build a new building in order to support that work that started in 1970. We're out of space. We didn't meet ADA standards. Whole array of framing out the building for the future. We started by creating some core values: hospitality, integrated care, clinician joy, stewardship, and presence. And we got a beautiful, beautiful design from an organization, HKS, who helped us with the design of the building. So we're expecting to move in June. Triples our square footage, doubles our clinical space, allows us to grow for the future. So teaching kitchen, a workout wellness center for patients. We finished all of our underground work. Concrete work is going on right now in level 4, and we'll have our certificate of occupancy at the end of May. These slides of our building. This is I'll pause here, and I'm conspicuously in front of K. Paul Holt. I want to pat myself on the back. No, I'm kidding. But we believe we knew getting started that we could keep the dollars local, and it's been really hard. Intrepid, Brian Nicholson's worked really well with us, but we've kept 76% of the dollars among local subs here in Waco. So we're really, really proud of that. I use the term here, I'm looking at my time, I've got 1 more minute. I use the term here, civic investors as opposed to philanthropists or donors, because the way I see it, people who contribute to our organization are civic investors. And 31 million of our 65 million total has come from that population. Donations have been 53% of that, individuals who have given. So these are Wacoans, residents of McLennan County, who know that this is vital and have given to see it happen. And we're right now trying to decrease the amount that we're borrowing and continue to raise as much as possible, because every dollar that we end up raising is a dollar that we're not paying interest on. So okay, that is it. And I see at 1 o'clock, I'm going to tell my team I did it. 76 slides. Thank you. Y'all were such a wonderful audience. We really, really appreciate it.
Well, I think all that means is that you're going to have to come back another time and finish up with the rest of your slides and give us an update on the status of the building. We'll look forward to that. Again, I apologize for the change in location today, but it all worked out. You're all still here, and that's good. I want to re-welcome our newest members as well as all the guests today. You're all welcome to come back again. Our next meeting is supposed to be in the Baylor Club on the 4th floor on August the 15th. And our program will be the athletic director, Mac Rhodes, with John Morrison calling the plays. So we hope that if you're going to bring guests, that you'll let Joanne know early. I have no idea what room they'll put us in, but maybe we can give you advance notice. I hope so. I want to thank all of you for attending today. And now please stand for our four-way test. Is it
the truth, is fair all concern, will build good friendships, will be